Dialysis patients are a special population. They sort of become very dependent. Patients on dialysis do have quite a few mental health issues coming in. For many years, 3 times a week, you get to know them: kidney disease, diabetes, obesity, again, the unholy marriage of all those metabolic conditions. We need to prevent. Rather than thinking of treating the end stage, if it was not on my watch, that person does not have to die. Social media is a place where everybody could say anything. We took some hits, but hey, you saved quite a few lives in the process. It's a fair trade-off.
Hello, I'm Michael George of Sagesse Healthcare Consulting, and this is the Pioneering Patient Podcast. This edition is brought to you with the support of the Global Patient Alliance for Kidney Health. In their younger days, my guest toyed with the idea of either becoming an astronaut or a doctor. Happily for patients in her native St. Lucia, she chose medicine. And in 2013, she became the first native-born nephrologist, that's kidney specialist, in the history of our country. In those days, patients faced the threat of dying because of a lack of access to dialysis machines. As a result, she became a powerful advocate, unafraid to confront politicians in a mission to change the situation for patients. So, Dr. Merle Clarke, welcome to the Pioneering Patient Podcast.
Thank you for having me. Happy to be here.
Wonderful. Well, thank you. First, tell me about your job, what you do currently.
Well, I'm a nephrologist. I work predominantly in St. Lucia, which is where I'm from. St. Lucia, the land of the fastest woman on earth, Julian Alfred, who won the Olympic gold medal in 100 meters at the Paris Olympics last year. So I work predominantly as a nephrologist, all aspects of nephrology, in prevention, in treating patients on dialysis. I also do a lot of advocacy work in St. Lucia and to a certain extent in the broader region.
You've been talking today about cardio-renal-metabolism conditions. So these have all been put together. So tell me more about that and the work that's taking place.
All right. So it's metabolic, cardiac, and kidney disease. Those things are intertwined. Again, to say diabetes is a leading cause of kidney disease, followed by hypertension. Kidney disease, once somebody develops kidney disease, they have an independent risk factor for heart disease. There's a syndrome called cardio-renal syndrome and also cardio-metabolic syndrome. Essentially, it's sort of like unholy marriages. One thing could potentially lead to the other. So when you have kidney disease, because of the anemia, because of the stress on the heart, because of that, and because of so many other factors, because you're essentially retaining toxins that ordinarily your kidneys would be getting rid of, because as a very important function also of the kidneys, getting rid of those excess toxins, that complicated to name them here. But of course in medical school and among medical practitioners, we know what these uremic toxins are. All those things just sort of converge and could lead to become an independent risk factor for heart disease. But once the heart is affected, for example, if somebody has heart failure, in that case, the heart is not pumping blood effectively to any of your organs really, so be it your brain, your kidneys, or the heart itself, then the kidneys could be compromised. So this cardio-renal syndrome, one affects the other and worsens the other. The kidneys regulate your blood pressure to a certain extent. So if your kidneys are not working as they should, your blood pressures go up. But remember, we also said your blood pressure was a major risk factor, the second leading cause of kidney disease. So the high blood pressure is damaging the kidneys. The damaged kidneys are causing more high blood pressure, so it becomes more difficult to control. You need more medications. Patients do not like to take medications, so it all becomes sort of a whole perfect storm. So it's important that we manage those things together as opposed to viewing them in silos. So the cardiologist has to work with the nephrologist, has to work with the GP, who is the person who initially should be doing the screening to ensure that if a patient has any of those diseases that we mentioned, that we catch them early. That if there is kidney disease, if we're finding protein in the urine, something that's very important that sometimes even our physicians forget. If there's protein in the urine, that person needs to be looked at. There should not be protein in your urine, and if there is, what it means is that the kidneys are allowing it through. It means they're damaged, because when they're working as they should, they don't allow that. But this same protein in the urine or proteinuria is an indication of heart disease in and of itself, so what we call endothelial dysfunction. So those two things are so closely intertwined that managing them together, I mean, all the specialists working together, all physicians working together with the patient is exceedingly important. And importantly, most of the I should say quite a few of the medications now that we use in kidney disease and newer therapies also would be used in heart disease. So the world recognizes that we must treat those things as one because we are treating one patient.
Yep. And you talk about seeing the signs early, so early screening and early intervention, which we want, and we'll talk about that in a minute. But what you don't want is to get to dialysis.
Absolutely.
But tell me about the life of a dialysis patient. You say you get to know these people, you see them 3 times a week. What is that life like?
Dialysis is life-saving. There is no question about that, because a patient who has stage 5 kidney disease, and I think we want to make it clear, we're not dialyzing everybody who has kidney disease. It's only patients with late stage or stage 5 or end stage kidney disease who require dialysis or kidney transplant or peritoneal dialysis. But what is the life like for a patient on hemodialysis, which is the one most people know about? So in that case, you have a patient whose kidney function is very poor. So on average, there's something we use in medicine called the glomerular filtration rate. What that gives you an idea of is how well or poorly the kidneys are functioning. So us sitting here, we expect our glomerular filtration rate to be above 60. If you're younger, you're 20, 30, it's in your 40s, you expect it to be above 90. As we age, it does tend to drop because we're aging. It is going to drop, so that's considered physiological. The person with kidney disease, however, and that's how we stage kidney disease, as the kidneys are damaged, this number tends to drop. So in your nephrology clinic, that is what you're calculating. Looking at symptoms, which, as I said, they will not have early on, but if I have somebody who last year, for example, had a glomerular filtration rate of 70, and this year is 50, and I see them in 3 months, it's 40, we have a problem. Houston, we have a problem. So we absolutely have to look at that, because your glomerular filtration rate should not be falling at that rate. So when this person has stage 5, that means the GFR is below 15. So that person then may start to have symptoms. There are many who do not. There are many patients who, even with a GFR as low as 8, don't have symptoms. But that's when you know that to prevent further heart compromise, you need to start renal replacement therapy. So that's dialysis, transplant, or peritoneal dialysis. When that patient who is on hemodialysis, if that patient was detected early in their course of kidney disease, and by early, I don't mean the patient who's discovered very early, if we do what we're supposed to do and educate patients, generally does not get to the stage where they need dialysis, because you're able to control those risk factors, the diabetes, the hypertension, the anemia, the protein in the urine. The patient, however, who comes in, say, with a stage 4, a GFR of 20 or 17, something to that effect, that patient is probably very likely going to develop end-stage kidney disease eventually. Your job as a nephrologist is to slow that down in as much as you can. But you're not God. At the end of the day, there's only so much you can do. Eventually, they're going to develop end-stage kidney disease. So what we need to do there, as I said, is slow it down and prepare them. If you get that patient at that stage, part of preparation is ensuring that they have what we call access for hemodialysis. And that includes getting them to go to the surgeon to get something called an AV fistula done. A fistula is basically a shunt done between an artery and a vein to allow for dialysis. Because now when they go into dialysis, what is done essentially is they get 2 large bore needles put in that shunt that has been created. One is removing the blood. That blood is then being purified via a machine and membranes, a complex process, and that blood is returned. That patient sits there for 4 to 5 hours, 3 times a week generally, and that is done. But what we want, when patients complain, that's a lot of time. What we nephrologists remind them, remember your kidneys are working 24 hours a day, 7 days a week. So compared to that, 3 times a week, 4 hours is not a lot of time. The reality is there are patients who do not tolerate it. They don't want it. They can't stay for that amount of time. They have to pick up their children. So a series of factors that come into play that could affect how well a patient is treated or how well their dialysis is being done or not. Because we always say kidney disease is not just a physical problem, it's a biological problem, it's a social problem, it's a financial problem. There's so many implications to it, because that person generally is not working or needs time off from work. That person, their family has to be involved. When they finish dialysis, they may not feel well, they may feel weak, because the process of dialysis, you're not only removing toxins, you're also removing fluid. Sometimes you don't calculate well how much fluid you should remove, or you think you have it well calculated, but you don't. But if you pull too much, that patient essentially is dehydrated, so that patient is not feeling well. Now, it is our job, if we're doing our jobs well, as nephrologists and as renal nurses to ensure that we're pulling just the right amount from that patient. Some of our patients, especially if they've been on dialysis long term, they don't urinate at all. So that patient, you definitely have to remove fluid. Those who still urinate, you may have to remove less, but the reality is that patient should leave dialysis feeling better, but that is not always the case. And that has to be taken into account. So essentially, you come in, you sit, they do create a community, because remember I said those are patients who come in for years on end, 3 times a week, so they know their fellow dialysis patients, but 2 large bore needles are put in, and the process is done over a 4-hour period. Some of them, they bring in a book, they read. Some of them fight for the remote to decide what we're going to watch on TV, but it is not, it's life-saving, but it's not by any means an easy process.
So clearly you want to have the disease diagnosed well before you get towards dialysis. And your meeting you had today in Geneva with the Global Patient Alliance for Kidney Health was talking about early screening and intervention. Tell me more about what you're talking about at that meeting.
So early screening essentially means recognizing who's at risk. And we mentioned earlier who's at risk. Your patient who has been diagnosed with diabetes, your patient who has been diagnosed with hypertension. Importantly though, here we must point out that there's a large section of the population who has high blood pressure who doesn't know. Because high blood pressure in and of itself is known as a silent killer. So unless you're checking your blood pressure, you may not know that you have high blood pressure. So a plug in here for checking your blood pressure. At least once a year, we must get our blood pressures checked. If you have risk factors, if you're obese, if you have certain other pathologies, even more frequently. But your patient who is diabetic, your patient who is hypertensive, your patient who has HIV, your patient who has lupus, your patient who has a family history of kidney disease, your older patient, all those people really should be screened. Your patient who has heart disease, very importantly, they have to be screened for kidney disease. What that entails essentially is some blood tests, your physical exam, of course, some basic blood tests, your kidney function tests, and urine. We cannot forget urine. The urine, you know how we say the eyes are the windows to the soul, the urine is the window to the kidneys. Whatever is happening in the kidneys will manifest in the urine because that is where urine is being produced in the kidneys. So those are the basic things that we do in terms of screening. In some patients, they may require an ultrasound or radiological studies, but for the most part, those are the basics. And if something is going on, you would be able to catch it there. That patient normally is with your GP, your general practitioner at the time. So also the onus is on us as specialists to ensure that there's training, and the policymakers as well, training for our general practitioners to make sure that we are doing the adequate screening. Because a patient who is found early does not have to develop late-stage kidney disease. A patient who is found early is much cheaper, to manage them. And I mean, policymakers speak money. They understand money, they understand finances. So sometimes it seems difficult for them to understand, but we need to get them to understand that if we catch patients early, if we screen patients early, it becomes much cheaper for them as opposed to having to pay for dialysis or kidney transplants, and then they become the heroes, because that's what they want. They don't want to be the heroes at the end of the day.
So what can health systems be doing to ensure this early screening?
Right. Providing the training, essentially, ensuring the sensitization of the general public, because also as a patient, you do have a right to say, hey, and I do tell patients that, if your doctor forgets to check your urine, say, hey, doc, we're checking my urine this year. You should be able to have a conversation with your doctor. On a policy level, though, we also believe that you need to have more physicians. They need to have more time in the clinic. It is virtually impossible to see a patient well in 5 minutes. Because how are you expecting me to examine a patient's breast, to examine their prostate, to ensure that their urine is tested, I'm reviewing the labs, ensuring the sugars are well controlled, the blood pressures are under control in 5 minutes. It is simply not feasible. So they need to create the conditions where you have enough physicians who have enough time with each patient to ensure that they're being treated well, so we prevent those complications. I think doing that really would go a long way in helping the problem. Of course, patient education, patient sensitization, know yourself, know your numbers, self-management. This is not about your doctor and your nurse alone. You have a big role to play there. So I think just the sensitizing of the patients, ensuring that adequate medications are available, for example, for patients with diabetes and hypertension and other pathologies, and ensuring you have enough physicians and healthcare workers to help those patients along their journey.
So if you're screened and diagnosed early, what interventions are there then possible, both perhaps a quality of life, but also drugs, other things?
There are so many options available to us in terms of treating hypertension, treating diabetes, which I keep going back to those because those are the leading causes. Yep. So in a patient, for example, who's screened early, who's at risk, a family history of kidney disease, and you screen that person and they have proteinuria, then you may refer to your nephrologist. Let's figure out why. That person does not necessarily have hypertension or diabetes, but let's figure out why they have proteinuria. Then you may be able to treat that. And in some cases, it's a curable problem. So that person does not have to develop end-stage kidney disease. So the early screening allows you to treat. And for many years, nephrology we did not have many tools in our arsenal, but there are more tools now. So it really is incumbent on all of us to ensure that we're doing the screening so the patients are adequately managed. In some areas of the world, some of the medications are still quite expensive. And again, the policymakers do have to come into play here. Because ensuring, I'm not sure if here the concept of the formulary exists. Whichever medications on the formulary normally would be available in the public sector as such, a lot more affordable. But some of the medications that we use that are key to preventing the progression of kidney disease can be quite costly. And I mean, we believe as physicians that every patient has a right to the best healthcare. So healthcare should be equitable. And it really should not depend on how much money somebody has. But unless you get a drug on the formulary, it really could be out of the reach of many patients. And we want to do away with that as part of our advocacy, that those basic drugs that we know has been proven to help protect the heart, protect the kidneys, must be on the formularies. Yeah. So that's what we're working on at this point. So there are medications available.
Yeah, and so that brings 2 points. One is, if you look at the prognosis of a patient who's screened and started treating early, how does that differ to a dialysis patient? And then if you look at, you talk about costs, but also there's a payback because these patients are working, contributing to the economy. So I'm asking you 2 questions there about the prognosis and then about the
prognosis
payback.
Is significantly better because you're dealing with a patient, for example, we could have a patient who has protein in the urine, but a glomerular filtration rate that we spoke of 70. There is no comparing. It's chalk and cheese. The patient with a glomerular filtration rate of 70 compared to the glomerular filtration rate of 20. 20, your mortality rate is much higher. 70 is practically like the general population. So 70, we're working on controlling risk factors, controlling the blood pressure, controlling diabetes, and we have many options for medications for that. If they do have diabetes and or hypertension, or if there's something else, then we could treat that. In a patient, for example, who has lupus, it can be managed. We are not saying that we are always successful in managing those things. There are patients who will progress despite the best medication in the best parts of the world. And I mean, somebody who stands out in terms of lupus, for example, Selena Gomez. Selena Gomez would have had access to the best medications, but she still developed end-stage kidney disease and required a kidney transplant. And there have been other cases. Tina Turner, for example. But the reality is the average person, if you catch them early, the mortality rate and the odds of them becoming very ill are way lower than what it would be if you did not catch them early and they developed end-stage kidney disease, significantly lower.
And so the situation in St. Lucia, compared with other countries, is probably not optimal. Tell me more about the situation in St. Lucia.
So definitely not optimal, and for some of what I've spoken of today. So we don't have all the medications that we know are available. So some of them may seem like a big term to the average person. SGLT2 inhibitors, even drugs, for example, what we call GLP-1 receptor agonists, so Ozempic, most people know that. So, I mean, treatment for obesity and that sort of thing, not readily available. In fact, practically unavailable in St. Lucia, except if you have a lot of money or a fair amount of money. So those medications are pillars in the management of kidney disease, diabetes, obesity, again, the unholy marriage of all those metabolic conditions. But we don't have them readily available unless patients have the money to afford them. So that's part of the problem in St. Lucia and the wider Caribbean. The lack of resources, the lack of financial resources on the part of patients, the lack of physicians. There have been improvements, again, thanks to Cuba, and the number of doctors that come out of Cuba and to a certain extent Taiwan now. So we have quite a few scholarships coming out of Taiwan for medicine. So we've had improvements over time with medical staff. But the Caribbean is facing a serious shortage of nursing. Why? Because the nurses are moving to greener pastures. In a sense, so when you're winning on one front, you start losing on the other front because the reality is St. Lucia can't compare in terms of what you could pay a nurse. We see the US or probably Geneva, here in Switzerland, or so many other places in the world with more financial resources. So the resources not being available is a problem. Dialysis, we've had improvements in that we don't have patients dying as such for lack of dialysis as we did in 2014. We've had significant improvements there. We have quite a few patients who are dialyzed in the private sector, but with government sponsorship. But we still, to a certain extent, there are patients who maybe are right on the edge, and perhaps if you were in the US, you would have been, but we don't have the capacity right now. So age comes into, so we don't want to be ageist, but the reality is sometimes it comes into play. We don't have kidney transplant programs, so in the Caribbean, it really is just Trinidad and Tobago, to a lesser extent Jamaica and Cuba as well. They're doing kidney transplants, and transplants really are the only way of dialysis in a patient with end-stage kidney disease or who has or may not have started dialysis. So a kidney transplant will allow you to get off dialysis. We don't have that option in the Caribbean, so limitations in terms of resources, limitations in terms of healthcare workers is a problem in St. Lucia, and I dare say the wider Caribbean.
And you talk about 2013, 2014, when you first became a nephrologist. The situation was patients were dying because of lack of access to dialysis. And you then became an advocate on their behalf, contacted politicians, advocating on their behalf. Tell me more about why you did that, what you did, how you did it.
Yeah. I mean, essentially, my view was not on my watch. We cannot have, so when a patient, I get emotional sometimes when I talk about this because it literally was, that person does not have to die. Yeah. If we're able to get that person dialyzed, then that person did not have to die. But you simply did not have the capacity. If we were at capacity at the unit, there was nothing more that we could have done. And I think it was Christmas, was it 2014? A patient had said, because the family of a patient said, can you even do 2 sessions so she makes it to the new year until her daughter gets here? And those things are heart-wrenching. I'm like, no, we have to do something. We cannot have citizens of St. Lucia dying for something that we could prevent their death. We're not God again, but we know that deaths are preventable, at least for a couple of years, or quite a few years in the case of some patients. So we started our campaigns then to raise awareness of kidney disease, because again, talking about medicine is not always the sexiest thing, and much less so kidney disease. So what you find, the patients who knew anything about kidney disease would be patients who have a relative on dialysis or patients who have a relative in kidney disease. We did not have very well organized kidney clinics. So we felt we needed to get that going. So we captured those early patients and we're slowing down the progression to dialysis because we understand we didn't have the capacity for dialysis. So started going into the schools to talk about kidney disease, going to workhouses, going to business places, so just everywhere. Once the time, we sort of had the time, and then that is in itself is limited because you have to get work to do at the hospital, but teamed up with the St. Lucia Renal Association, the St. Lucia Diabetes and Hypertension Association, and started at Advocacy work, speaking to the personnel at the ministry, including the permanent secretaries. We started this Celebrity Sports Day in 2015, so that brought out celebrities, bring people, and every country has their celebrities, so we felt if we do a sports day where we could, so you're promoting their physical activity, but also getting the celebrities out, getting the musicians out, getting them to do their thing, and also educating. So have different organizations, the Cancer Society, just educating people who are there on the day. That was fairly successful for us and also allowed us to make some money that we could use to help patients purchase some of the medications that they need, like erythropoietin, which our patients on dialysis need, because remember I spoke earlier of having anemia because you're not producing erythropoietin. So that drug is expensive. So patients need assistance with that. So we were able to do some of that for the patients. And with that advocacy, it became somewhat of a political issue. In the Caribbean, Caribbean is a small place. The islands are small. Anything that's going to cost a politician votes is going to become an issue. And that became an issue that we had at the time, 85 patients on a waiting list for dialysis. These are 85 patients who were going to die if we weren't able to dialyze them in a timely manner. So that really blew up and became an issue. And of course, then more action was taken. So this was going to cost votes, essentially. So they knew they had to take action, and that's where it started. So we're at a point now that we don't have as many patients, or practically very few patients, who would die because of lack of dialysis. So we still don't say dialyze patients with cancer, for example, especially late-stage cancer, whereas in some places there would be, we don't, because again, resources are not optimal, but we are in a much better place in 2025 than we were 10 years ago in terms of that.
Yeah. And so this advocacy, political advocacy as well, isn't always comfortable for you because you've faced threats as well.
Absolutely.
And so tell me more about that and whether you're still going on to continue to advocate.
Absolutely, we continue. And on top of that, I'm president also of the St. Lucia Medical and Dental Association, which also requires a certain amount of advocacy. Because if you say, hey, our doctors are tired, you need more doctors, you need to hire more people, we need more to do everything that to keep patients alive. It's not normally the politicians. Politicians are subtle and they're smart. Yeah. So normally they have their agents who would sort of say, oh, why is she talking about that? And this is clearly politically motivated. And it's because whoever is in power believes that you're working on behalf of the opposition. Yeah. And that's just the reality in the Caribbean. Yeah. It's a reality that you accept and understand that those are the things that are going to be faced when you speak up. Because again, if you speak up for nothing, you may be very safe and quiet, but I think we sleep well at night knowing that we saved lives. Yeah. Okay, we took some criticism, okay, we took some hits, but hey, you saved quite a few lives in the process. I mean, it's a fair trade-off.
So you've had to go out and take on those who've threatened you and say this is not going to happen.
Absolutely. And it's not so much physical threats, it's that social media is a place where everybody has a voice and everybody could say anything, whether they invented it or not, but we learn to deal with that.
Yeah. I'll ask you about what you'd propose advocacy-wise to government. But first, let me ask you about two groups. Politicians are important, healthcare system is important, but also patients. What should patients be doing to improve their outcomes and their prognosis? In
terms of patients, as we said, I think we as physicians need to make it very clear to the patients if they're sitting in front of us, but also through using media, social media, conventional media, podcasts like this, for example, to advocate for patients to understand that you live with yourself most of the time. You may see me as a physician every 3 months, but it is important that if you are completely healthy, wonderful, we want you to stay that way. Diet, exercise, all the things that we all know that we should do. If, however, you do have a chronic disease that can potentially lead to chronic kidney disease or heart disease or anything else, any complication, serious complication, what we want you to do is know your numbers. Understand how to manage yourself. So you're on insulin. If your blood sugars are consistently high, you don't need to wait 3 months to see me to let me know or to adjust your insulin slightly. You could call the office, you could call the hospital. So you need to learn to manage yourself, know your symptoms. Any patient with diabetes should know what it feels like if their blood sugar is low. And those are the things we try to educate. And there are quite a few self-help programs or self-management programs that we encourage patients to participate in because it is important. But again, lifestyle modification, very important. Because diabetes, there are cases which are not, like in type 1 diabetes, but diabetes for the most part is a lifestyle disease. So it requires lifestyle modification to manage it, in addition to sometimes medications. But there are patients who have diabetes who can be managed with just diet and exercise. And that's excellent, because many people think that doctors are pill pushers and we just there to give you medication. That is far from the truth. The reality is sometimes you're writing a prescription and you're up to 9 medications, like, geez, if I had to take all those medications, that's a bit much. That is a bit much. So it is untrue, I would say, that doctors are trying to give patients more and more medications. We do it when it's absolutely necessary, when guidelines and studies have shown that this is going to prolong your life. We absolutely do it. But for the most part, we try to encourage just more lifestyle modification, living a healthy life, balanced diet, so you do better for yourself, and learning to manage yourself, your stress levels, your mental health, also important in any chronic disease. Because if somebody has a chronic disease and they're depressed, they may not take the medication. That may lead, if they require that, of course, that in and of itself may lead to more complications and so on. So essentially ensuring that the patient knows themselves, knows their numbers, adheres to their medications if they do take medications, and they keep their doctor's appointments or with whichever healthcare provider.
And when it comes to healthcare professionals, it takes a village really to treat a patient with kidney disease or cardio-kidney metabolism disorders. So tell me how you're working together there. The role of, I think you were talking earlier, in the primary care, the physicians, the GPs, the nurses, others. So how does that work together?
Your dietitian. So what we try to do, for example, in the early stage, we try to ensure that you have a dietitian, for example, because so critical, our dietitians in all your renal clinics. It would be ideal if there were dietitians in all the clinics, because if we could prevent, we would be doing much better if we prevented or detected early kidney disease or any of those other diseases. But what we try to do sometimes at a hospital level is ensure, because no patient wants to be coming to the hospital 3 times in the week to different multiple clinics. They do get tired, and there's a certain amount of fatigue. Once you have fatigue, then they don't come, and then you start having those problems. So what we try to do is consolidate the clinics. So the cardiology clinic and the renal clinic are on the same day. If I need advice from the cardiologist, so okay, I'll see, but tell me from your end, this is what I've heard from this patient. I've examined the patient, so you don't have to necessarily go. If you trust my judgment, which we do, trust each other's judgment, tell me what we're adding. So we try to help the patients in that way, so they don't have to come so often. So just working collaboratively, in essence, to make the life of the patient easier. And our workload is decreased as well, because if I refer a patient to cardiology, it may take 3 months for the patient to get to the heart specialist, and that simply sometimes cannot work. And to prevent an admission, so before the 3 months, that patient may be admitted to hospital, and we want to avoid that. It costs the country more. It's more work for us to do. It's more work for the patient to do, the patient's family. So we just try to work with hospital management, with the whole healthcare system, to ensure that we're consolidating our clinics, our advice, our dietitians, our pharmacists, that everybody's working together in the best interest of the patients.
So, final question. If you were invited in by the Minister of Health of St. Lucia, and they say to you, right, okay, Merle, Dr. Clarke, what do we need to do to transform the situation for kidney patients in St. Lucia? What would you be advising?
I think the main things we would advise is we need to prevent. Rather than thinking of treating the end stage, which we realistically cannot do, we don't have the money to do it. We've taken care, for the most part, of people not dying because of lack of dialysis, but we need to focus on prevention. We need to focus on managing more effectively diabetes and hypertension. We need to focus on patients understanding their diseases. So again, education. So we need to focus on education and prevention, and ensuring that the necessary medications are available for the patients that need them, so we prevent those complications, which are significantly more expensive to treat. They're more labor-intensive, they're more resource-intensive. So let's just look at the front end of the problem and work there, put most of our efforts there, so we prevent those expensive complications, essentially.
So we hope you do have that meeting with the Minister of Health.
Absolutely.
You've got a lot to advocate. Thanks for advocating on behalf of patients. Thanks for joining the Patient Podcast. Thanks for what you're doing for patients.
Thank you for having me.
Well, thank you to Dr. Clarke for a fascinating discussion today. Thank you to you for joining this Pioneering Patient Podcast. And thank you to the Global Patient Alliance for Kidney Health for supporting this podcast. And finally, please remember to take good care of your health.